Muy buenas tardes.
I'm the director of the
Soy
Institute at the Wilson Center. On behalf of the Mexico Institute, the Maternal Health Initiative, and the Environmental Change and Security Program, I'm delighted to welcome you to this afternoon's program. March is Women's History Month, as I'm sure you all know, and there's no better time to engage in a conversation about women's access to healthcare in Mexico. We think it's important to keep in mind that while the COVID pandemic has exacerbated a number of healthcare issues in Mexico and frankly around the world, the systemic challenges and deficiencies in the Mexican healthcare system predate COVID, and if not addressed, will continue even post-pandemic. To ensure that these challenges are not forgotten as we move out of the pandemic, we've assembled an excellent panel this afternoon to highlight the challenges facing women, including those in Indigenous communities, and to talk about possible policy solutions that can improve women's access to healthcare in the future. I'm delighted to introduce today's moderator, Lila Abed, the Deputy Director of the Mexico Institute. Lila joined us earlier this month, and we could not be happier to have her. Lila has a wealth of experience in government and in the private sector, and as a dual national really embodies the objectives of the Mexico Institute to enhance understanding, communication, and cooperation between Mexico and the United States. Lila, I'm delighted to publicly welcome you to the Wilson Center and to turn over the moderator duties to you for this afternoon.
Thank you very much, Andrew. It's an honor to be part of the Mexico Institute at the Wilson Center. I'm going to transition to Spanish. Pero le quiero dar la bienvenida a las tres panelistas que nos van a
Let me cordially welcome the three panel members that will talk to us today about an area which is very relevant in Mexico and around the world, given the fact that access to health services for women is still quite a challenge at the global level. Even the United Nations are telling us that basically in regions such as Africa and Latin America, but in Mexico, in accordance to many sources, there are 18 million women that are a part of INSABI, which is was used to be called as Seguro Popular, and the complaints given how precarious the service is and the lack of medical and health infrastructure is quite relevant. It's presenting insufficiencies and failures that prevent the full exercise of the right of health, and it also includes 16 million women. That is 24.7% of the country's population. It is inequitable for the poorest population. The pandemic complicated the situation and caused a considerable limitation in the attention given to women in areas such as family planning and reproductive sexual health. The health crisis for COVID-19 made obvious the inequalities of gender that were pre-existing and access to health of women. Our three panel members today will talk to us about this and other barriers that prevent women to have health access, such as poverty, the lack of budget, the geographical location, the impact of the COVID-19 pandemic, and the public policies that can be promoted in favor of women, among other areas. Now, we will start this session, but first let me remind our listeners that we have simultaneous interpretation. You can use the globe icon in the lower part of your screen, and that is where you will be selecting the language of your choice, either into English or Spanish. And let me also say to our attendants that if you want to send your questions or speakers, you can do it through our Twitter account. We are at Mexico Institute, also through email, mexico@wilsoncenter.org. The recording will be also made available by the end of this event. And having said this, let me start this session. And we shall start with the participation of Ms. Irena Tello. She will cover the current scenario of access to health services of women in Mexico and all the barriers that they're still facing. Now, our panel members have quite a broad trajectory, but I will try to summarize their profession. Irene Tella is the executive director of Impunidad Cero. She's a journalist at El Universal. She's a blogger at Este País and a professor at ITAM. She has master's studies in international affairs by the New York University, and she is a former intern. She also has a license and a law degree from the National Autonomous University. So, Madam Tello, the floor is yours. Thank you. Let me set my clock. So I will start sharing a presentation that I have prepared to share with you what we do at Impunidad Cero in regards to gender and health, which is where these two major problems cross paths. Tell me if you can see my screen being shared. Perfect. Very good. Well, let me just share with you what we're doing at Impunidad Cero. Impunidad Cero is a civil society project dedicated to analyze, measure, and check impunity in order to fight it. In 2016 is when we started, when we found that there was a good opportunity window to consider this topic. And well, this was an area when impunity and corruption were considered to be the same phenomena. Several of us worked previously in Transparencia Mexicana, and we knew and we had to study impunity as a whole, as it is explained here on this quote, where we are asked about what impunity is all about. I find it very relevant to bring this definition, and given what I will explain to you. It has to do with the lack of allocation of responsibilities, of different types of responsibilities and liabilities, not only civil, criminal, administrative, violations of human rights. And this is happening because there's not the right prevention nor research work or nor sanction if it merits given their action. But all of this must be focused based on the fact that this is compensating the damage caused to the victim and it will not happen again. Now, many of these things in the area of gender violence and health, when we talk about impunity, we have to direct our attention here. Unfortunately, we can see the theme axis that we cover at Impunidad Cero. The gender violence is one of the topics that we have approach since the beginning of our organization. In order to approach these elements, these are some of the areas of research. There are endless topics when we talk about gender violence and impunity in access to health services, but unfortunately, in all of our research work, more so the ones that have to do with gender violence, the element of cross-cutting elements is quite concerning for us. When we see all of this, it's important to mention that it's not only necessary when we're talking about gender violence to make a distinction in regards to gender, but other categories that are crossing this type of violence and that are making it more intense. An issue that we constantly analyze in our institution has to do with gender violence and people with disabilities. We still need to touch this far more in the country. And obviously, when we started analyzing the health issues, the first element that we focused on is the corruption in the health sector, because what ends up translating into a lack of public resources allocated to provide health care to a larger number of women. Nevertheless, this year we have worked together with HIDE, which is an organization dedicated to reproductive health. And well, what we have touched with HIDE is to try to identify how much the obstetric violence and maternal death has been part affected by the presence of impunity. So what I mean to say, if there is maternal death and obstetric violence in Mexico, what has been created by Mexican state to identify these problems, to approach them, and for them not to take place again. Here, let me start with some data just to place you within context of the obstetric violence in accordance to ENDIRE, which is the survey of the dynamic of households conducted by Inequity, the Statistical Institute of Mexico, between 2011 and 2016. 33.4% of the women interviewed from 15 to 49 years of age that gave birth or had some type of ill treatment by the health care personnel that looked after them. These abstract figures, it's important to place them within context. When we came back from the review of ENDIRE and we identified the type of violence that women are enduring and the levels of violence, normally the percentages that we see are very high. Just to mention that of the women that had gave birth, 33%, that means one of every three reports that they endured obstetric violence. It is very important to realize the size of this phenomena in which we are immersed and that we will embrace when we touch uh, gender health. Now, almost half of the women that were surveyed reflected that during the birth of their last child was given a cesarea. That's now 10.3% say that they were not informed of this, and 9.7% say that there was no authorization requested to perform this surgery. So this is obstetric violence, and we're seeing these figures in other type of phenomena. The NDIT is also reporting that 14% of the women that suffer some type of obstetric violence were placed some kind of a contraceptive methodology. They were subject to a surgical process for sterilization in a permanent way with no consent. This is what is happening of carrying out this forced sterilization of women that are so seriously impacted. But we have to see that this is a constant practice in Mexico. And now what comes next is what's happening now in regards to the obstetric violence as other types of gender violence that come hand in hand. They can end up with causing death of women. The reason for maternal death is a 46.6 maternal deaths for every 100,000 births estimated of living children. This is one of the issues that is of great concern together with HIDE, because even though we had achieved a reduction in the maternal mortality as a result of some decisions that I will explain to you that have been taken by the federal Mexican government, there has been a considerable increase in maternal deaths. And this is telling us that the health system has not yet achieved to identify the failures to prevent obstetric violence. But even these failures are so large, so structural, that they end up producing, in many cases, the death of these mothers that have received health care in the public institutions. As you may see, and this is something that will be approached with greater detail by the following speakers, in the last 10 years in Oaxaca, Guerrero, Nayarit, and Chiapas states, they have held the first ranking positions in regards to maternal death reasons. So this is an issue that, looking at the cross-cutting elements to analyze, we have to explain this. It's not the same to see the violence in the state they live, their socioeconomical condition, if they have a disability. All of these elements have to be approached in order to identify which are the failures here. And these are some of the steps taken in the analysis that will be presented in May together with Kire to understand impunity and obstetric violence. When we carried out this research work, it was difficult to explain to people what is the relationship between impunity and reproductive health and reproductive health justice. When you talk about impunity, quite often people think about something that is failing, as it could be obstetric violence or maternal death. And well, what we normally propose is higher penalties and sanctions. What are we going to do with a doctor that is not providing good health care? Yet, what we wanted to propose in this study, if we will identify the structural failures of the healthcare system, however, in many of the states, we're going to try to conclude with this maternal death and maternal violence and get it over and off our system by identifying what is working. But, well, basically, this is putting women at a greater risk of being the victims of this type of violence. So this is why the definition of impunity is really relevant. It's impunity zero. It's useless to identify an infringement, an irregularity, or any situation unless you have, as a contrast to this, a compensation of this harm and to prevent this violence to keep on happening. This is part of what we're focusing on. Unfortunately, we also have analyzed what is happening when we have obstetric violence in the country. And one of the things we find important to highlight has to do with who is giving you this health care. The one of the complaints that has been presented by women before a human rights commission at the state level or at the federal level. How long does it take for their complaints to have some type of reaction? As you may see, only to issue a recommendation from the date that the complaint is presented to the moment in which this recommendation has been presented is at least 606 days. Some of them take even 1,000 days. So we have to approach the time that we're taking to take these decisions. This also generates impunity. So finally, these type of mechanisms, though they're very important, they are not really settling and solving the infrastructure that is failing. Now, to conclude, let me mention another of the works that we have approached in Impunidad Cero, and it's core to share this with you within the country and to have greater echo of what is happening, given the lack of supply of medicines in the country. Now, in regards to this situation in the health center, the last research was in regards to COVID, how this was, how were their resources allocated. When we concluded this research in March of 2020, right before the pandemic of COVID-19, doctors and experts in the health sector started approaching us, so we will consider the lack of supply of medication in Mexico. So it took half a year to try to identify why there was a lack of supply of medicines, and well, the public decisions taken since the beginning of this current administration gave way to a lack of supply, given a change in the public policy in the procurement of drugs. So now I'm sharing this with you because one of the main questions for the forum was how the COVID-19 had impacted the healthcare given to women in the health sector. And I believe that this must be approached not only within the scenario of COVID-19, but also the decisions taken by the current administration within the changes in the health sector. The lack of supply of the medical sector is not just changing the model that we had centralized in purchases and procurement and giving it to an official that had no knowledge about procurement of drugs and medicines. This was given first to the Ministry of the Treasury, then to the Ministry of Health, but also followed by a series of topics that have been taken in regards to the public health sector in Mexico. The change of going from Seguro Popular to Insabi had a direct impact in the patients that need the most access to free health services in the country. And I believe that at the end of this, we are in a critical situation where we had a public health sector with many failures, like the ones that we can see at the beginning, and that I try to share them in regards to a health sector that leads to obstetric violence and maternal death. And now it is weaker given the federal decisions that are weakening the issue of the procurement of drugs and also the access of drugs that people have by not having the Seguro Popular. And now this change that will go from Insabi. Now it's important to talk about these topics because we can see how COVID-19 has affected as a whole the gender and health areas. But here I think we have to add not how the pandemic has impacted health access of women and the health services given to women, the decisions that have been taken from the federal government in regards to the procurement of drugs and the change of Seguro Popular to Insabi. I don't think that unless we understand these three problems, the public health recommendations that we'll do at the end of this will not be enough. And it's very important to consider the lack of supply of medical drugs. You can review the Colectivo Cero de Tabasco, where Impunity Cero is a part of, just to identify how since 2019 up to this moment, the number of prescriptions supplied in the different institutions of the public sector, IMSS, ISSSTE, INSABI, and the different state insurances uh, have increased considerably. So it is important to talk about what is happening in regards to this point, because it could seem that those prescriptions that were not supplied or the lack of supply of medicine took place within the context of COVID-19. But it's important to see that we have different causes for this. It became more acute with COVID-19, but the issue of the lack of supply of medical drugs is a relevant problem today, and it has to do with the decisions at the state and federal level. And unless we consider the relevance of this topic and solving it, we will continue having years where we will see this differentiation, not only considering gender, but also the social economic statues, where people with the lesser resources will be the most affected. And just to conclude and to share with you a point, I was sharing with you a few moments ago with the director of the Zero Supply Initiative, and he was asking me if we had data about how this lack of supply had affected in regards to the general supply in women. And well, just considering that most of the um, doctors' visits that take place in the public sector in Mexico have to do with women, we can realize that this lack of supply is having a greater impact in a higher proportion women. So this is a problem that we have in this country, and we have to overcome this problem. I thank you for this time. I know that I've touched so many areas, but impunity covers and touches so many phenomena, such as gender violence and health sector issues. And well, I'm open for any comment or doubt or question that you may have. We thank Irene Tello for this very interesting presentation. And well, it is alarming to see how impunity and corruption are affecting even the health sector and even in the area of violence against women in the health sector. Let's continue now with Federal Deputy from Oaxaca, Eufrosina Cruz. She will talk to us about how geography and development have an impact in access to health services of women in Mexico. Eufrosina Cruz is a representative from the Zapoteca ethnic group in the southern mountains of Oaxaca. Since 2007, she launched a struggle for the full recognition of the rights of women. She's a federal representative. She's an international uh, speaker, and through her work in building a better world for women for the Afro-Mexican and indigenous groups in Mexico. She's a public accountant by the Benito Juarez University in Oaxaca and has a master's degree in the state of Puebla. And before I give her the floor, uh, Madam Eufrosina, let me remind our audience that we have simultaneous interpretation. You can just select the language of your choice in the globe icon in the lower part of your screen, and that means you can select either English or Spanish. And if you want to send any questions to the panel members regarding your doubts or any topic you want to approach, we will have a session of questions of Q&A, and well, you can send them to us through our Twitter account, @@ Mexico Institute, or at wilsoncenter.org. So, Madam Representative, you're most welcome to this session, and we are eager to hear your presentation. On the contrary, I thank you so much for this opportunity. I am pleased to share panels with women as chingonas, as we say here in Mexico, and that we are from our different trenches. We're breaking paradigms and making the topics that quite often are not seen visible. And the health sector, with no doubt, and more so for indigenous women, is a triple challenge. In the urban areas, the lack of supply of medicine is visible. Now imagine what happens in the indigenous communities. But of course, health changes from region to region, and more so for women. The issue of breaking cultural paradigms, first of all, the issue of stopping the forced marriages that have to do with health, violence as a daily practice makes women to become invisible for health. And well, and a little bit of what was said by Irene of how it is to empower women and girls to break away from these daily actions that have to do with their decision-making processes on a daily basis. So, well, now uh, here we have what Irene was mentioning at this point. Now, how it is that when you why it is that we do not ask when the public policy is seen from a different perspective to simply closed programs that are not a part of your administration or your political party. Yet you don't think the repercussions that this has for daily lives, for the health of women, and how it is that the Seguro Popular programs impacted women, how Seguro Popular and the programs we had in place were empowering women because it had three lines involved: health, education, and food. And now, how it is that these programs have been closed, it makes invisible women again. Now, when you have a program and you're empowering women, and how it is that on a single stroke, you re-victimize women again. You im- uh, infringe them again. You make them vulnerable again, and you go back 10 or 15 years in time of what we had achieved so far. Now, within a community where daily activities, you have to get up at 3 in the morning and you're the last one to go to bed. When going to the doctor, because it is the male, because, for example, uh, the breast cancer and other types of cancer were present. And with these actions of public policy that were making women visible, well, there was a risk reduction of women. A 12 or 13-year-old girl that within these forced marriages, because this is what the mores and traditions of the indigenous people established it. How do you say to tell them that that cannot be happening? And accompanying them with all of these public policies that are setting back. And this doesn't have to do with a political party. It is an issue of empowerment, of setbacks, of the rights achieved by women within a community where, just imagine, let me share uh, with you an indigenous community image. My eyes, I was raised in an indigenous community. What I had to do is I had to walk 12 hours to the health center, you know, to have worms because there were no doctors. Look at your sister that she got married when she was 12, and when she was 31, she had already given birth to 9 children. And well, this is what we have to fight against because, you know, in these circumstances, and they started doing things, and she decided not to have any more children after 9 children. And with these public policies that were in place, well, it was obvious that there was a disease called cervic uterine cancer, breast cancer, and many of them have died because of this. Now, the maternal deaths. So we started seeing these problems because there was a space where they will be getting together to talk about human rights, equality, and also to speak about violence. Because in this issue, what have you done all day? Well, you haven't done anything, or you're useless to come here. What are you going to this other area? These situations were implicitly presenting violence, and these governmental programs and actions mm, actually helped us to awake the conscious, awareness of women. It is useless that you will say that I'm useless. It is useless that you tell me that my daughters cannot go to school, and you will not tell me how many children I'm to have. I mean, it's not normal that you will not give me the right to go to the healthcare center. These are paradigms that have to be changing in the regional health issue. Their health care vision in an indigenous community is quite different from the urban perspective. Now, add to this violence, add to this the lack of education, that many of them do not know how to read or write, they're illiterate, and then how you can break all of this. And well, you take away a single door to make them visible or a window to make them visible is a setback in the rights of women. The other question is how this growth and development changes in regards to indigenous communities and non-indigenous communities and how they impose any traditional limitations. I mean, if there is no health center in the town, if the health care house that should have all of these diagnoses, how many of these healthcare centers were closed when the Seguro Popular was closed and Insabi was created? The healthcare houses were space where there were no healthcare centers. So we created health houses where other women were trained in order to consider and provide what is was very basic, first aid to their own women in their own spaces. All of the health houses in indigenous communities were closed because through the Seguro Popular, these women were paid that were considering all of these health houses, and I mean, they were in communities that had no more than 1,000 inhabitants or 500 inhabitants. That is the orography of indigenous communities. They are communities that are really small. We have 570 70 municipalities and we have over 14,000 localities, and 70% of them have less than 2,000 inhabitants. So obviously, we cannot build a healthcare center or hospital in these places. So they created these health houses that were somehow empowering women. And also, they were trained and they would also speak their language, which is another challenge. In Oaxaca, Mexico, we speak 68 different languages. Uh, Now in Oaxaca, we have 16 different languages and they have variations. You know, Zapoteca from the southern mountains. There is a Zapoteca of the northern mountains, the one in the isthmus, the one in the northern area. How are we ever going to be able to cut things off without considering the consequences of these actions that were making women visible, that were telling women about their rights, that were telling them that violence is not normal, because in their daily lives, violence was normal. And suddenly, right with a brushstroke, we would delete and remove all these positions that manage to visualize the violence within indigenous communities is not something that is going to be get rid of overnight. And Irene helped us to present this. So that's why I'm so frustrated to see that suddenly, just because it is not part of their vision, it is not part of my vision, they cut down actions that empower women. Why is this? Because regionally speaking, socially speaking, economically speaking, culturally speaking, but of course, that the fact of education is quite different. You have to tell women why it is important that they have to take care of themselves. It's important that they go and visit their gynecologist because many of them have never had a mastography. They've never had a Papa Nicolau. So to get to them, it has been quite a challenge. Now, among themselves, it is very important because that is why it is so very important to consider the health homes that were in the different locations. It's important to bring them back because those that are empowering their own uh, women are the women that speak their language, that speak to them directly to the other women within their locations, and we have to break away from this. And it's quite a pity that this was closed and eliminated, the health houses in the indigenous villages and towns. And this leads me to another question, the access to health services of women in indigenous communities. Well, the percentage of this is very low. There is no health home. The healthcare center is 3 hours away. If they have any pregnancy complication, it's 8 hours away. Do you think they're going to survive going through all of these um, unpaved roads and get and ride a ambulance? When we're talking about public policy, we have to build this from the communities themselves, from the real context of communities. Just imagine the lack of supply of medicine. You think that within the healthcare centers in the indigenous communities there are medicines? Of course they are not there. So they have to purchase their medicine. And well, poverty, inequality, how do you expect them to ever buy their medicine? Let me say this over and over again. I mean, we need no excuses in the bidding processes. They cannot wait for the bidding processes that has to do with a change of structures or anything like that. They cannot wait. They cannot continue waiting another cycle because that is re-victimizing women in the health area. Also through public policies, re-victimizing women once again. So violence is re-victimizing them in the health area once again, in education one more time. So I mean, over and over again, this is quite a challenge in order to learn, relearn, and put right at the center the health care of women in indigenous communities. It's urgent, it's a priority. In 2018, the population that did not have health care was about 7 million women. Now, in indigenous communities, this percentage doubled itself. We have now women that are not given health care. Why is this? Because a program called Bienestar, which is resources for women with children, but it is not accompanied with the health component. It doesn't have this component. They are not empowered through this because the issue of opportunities that we had before had this component. It would empower women, truly. It was important to visualize them in these spaces. And now none of these programs goes along with this component. And I have said that the social programs have to go with components empowering women, visualizing their rights, because it's useless to have a subsidy directed to women if it is not accompanied by these additional components, because they're just generating additional violence where there is violence already. At present, for example, 20 hospitals at the federal level are registering 70 or 90% of lack of medical drug supply. In the indigenous communities, I'm not saying this. We have the data here. We have the statistical information. We estimate that there is a scarcity of at least 39 different medication to treat children's cancer. So imagine if the civil society in urban areas can see this, how do you imagine that children that have cancer in the indigenous community are living through? Well, just to bring the chemotherapy to the regional units, how are we going to do this given these situations? In accordance to this figure, this lack of supply has caused the death of 1,600 children in Mexico, and it has affected over 19,000 children patients that are given health care in the public hospitals. The justice system and the health system or the educational system do not make no reference to indigenous issues. Everything is built in Castilla, as we say in Spanish. All is in Spanish. No policy in Mexico is ever done in indigenous languages, in written or by the fact of listening. How am I going to tell women about their processes so they can go and have their checkup, have a Papa Nicolau, and if whomever is there in the healthcare center will only speak Spanish? I mean, what can I say? Over 52 million persons are in poverty, and more than 9 are in extreme poverty. And women are there in extreme poverty. And in extreme poverty, I'm also talking about healthcare. That is what has been identified. 8.4 million persons in poverty levels are of indigenous origin, and 3.4 of the population in extreme poverty are women. And here, let me repeat this again. Once again, in the health area, the health system in Mexico has failures that prevent the full exercise of the right to health. It excludes 33 million Mexicans. The lack for access for health services of the indigenous population considered 15.4%, while for the non-indigenous population, the proportion was of 16%. Nevertheless, in what has to do with health institutions for this same year, 72% of indigenous people have no longer Seguro Popular. There's no more popular insurance. No one is affiliated to this. So let's imagine that we have no figure of the number of people that do not have Seguro Popular in the indigenous communities. It was in general terms. Everyone lost the service. So it is quite a challenge. And now add to this the effects and the impact of the pandemic that re-victimizes communities over and over again, and indigenous women. Without internet, they cut down the program that is Mexico Connected. In Mexico, and basically in my state, there are two education subsystems, the indigenous bilingual system and the normal system, the indigenous subsystem in Oaxaca, where we have over 1,600 basic education centers of bilingual indigenous education. Prior to 2018, we had about 600 schools with connectivity, with internet connection. And I am fully convinced that internet connectivity should be a leveler in the area of health for women. And why am I saying this? Because it is within this space, this public space, that you can see the lack, the problems that they have in the health care center. They can see that the doctor is not there. You can see that you cannot bring a woman out in an ambulance. There's so many things that you can see through social media, and this possibility disappears once again, saying connectivity is missing. That takes away possibilities of children, boys and girls, to be connected. Now, education leveling has to do with technology. So if you get rid of all of these possibilities in the area of health, in the area of education to indigenous women, well, my frustration is how the hell are we doing to overcome what we had already achieved? And I'm saying this beyond political party influence. I come from an indigenous, my father died because the hospital is 6 hours away, and there was a river that in order to cross my father, they had to wait 12 hours, so the water levels will go down. And well, how was this solved? By building a bridge, something that is so obvious in public policies and they don't see it, and how these actions can build precisely bridges in the health area, not just a physical bridge, but all of these actions in public policy of how we can empower women, how we can empower girls, while in the public policy, the central area will not put health and education at the center of it. Because when a girl is educated, it breaks away from fears and paradigms. And of course, they will decide how many children they want to have or not to have children, if she gets married or not, and that no more tradition could be protected by the infringement and violation of human rights. And if we act to this, that in public policies we are violating their human rights, that is quite a challenge that we have to break away within indigenous communities. Well, this is all on my behalf. Doctor, the representative, we thank you so much for your participation and what you have shared, what Ms. Tello has shared with us. And there are several words that we have to highlight in both presentations, among them impunity, corruption, that the healthcare modules were removed, that many women do not have access to INSABI, public policies not directed to consider indigenous people needs. There's a lack supply of medicine. There is something missing. The medical procurement is limited. So we have to do effective actions to look after the health in Mexico. And with this, we open up the floor to Dr. Aranza Colchero, a titanic work that she has, and she'll talk to us about public policies in favor of women, which are the public policies that perhaps can work in favor of women in Mexico. Let me share with you a summary of Aranza Colchero. She is a researcher in the National Institute of Public Health at the uh, at the National Research Center, at the National Public Health Center. She has a PhD from the Johns Hopkins University, and she's a researcher in medical sciences. Dr. Colchero, the floor is yours. Well, I thank you so much for being invited to share with the two speakers that preceded me. I will be, can you see my screen? Good. Let me start with a situation that will seem to be very simple, but let me just share with you this element, just highlighting the health needs of women as they move in their life. And the first phenomena has to do with some issues that also have to do with children. But let's start with birth. Women can have nursing or breastfeeding, and the lower of breastfeeding in Mexico is very low. There is a lost opportunity that is really very important. In childhood, there is a major lost opportunity because even though the educational programs have to incorporate a part of reproductive health and the biological issues, there is very limited. It's quite inefficient. And sexual education for children, well, they're so young, I shouldn't talk to them about it. But no, children have to start, and basically girls in particular, because they suffer through their lives of different abuses, but also boys. But it's quite important to recognize that there's a lost opportunity here, because there are two very important elements of sexuality. One of them is that boys and girls will know what they are facing, what is correct, what is incorrect, and to know what is right, what is not right, and to be able to carry out prevention of their sexual life later on. And this is missing because schools do not have it. The parents cannot do it. And from childhood, that they will have a preventive area in order to know what is it they can have, but also the rights they have. What are the elements that they can enjoy? And this is very important for the growth of children. Then we have obviously the area that has to do with the reproductive health of women that starts basically at menka and ends up with menopause. And here we start a series of preventive needs that we identify. We continue with sexual education. We go on through the stage of adolescence and how the girls live adolescence. And there are very few programs for adolescents in general, for boys and for girls, but more so for girls, because precisely at this age, and since the menka starts, they can have sexual interaction, and this is a problem given their age. They can get pregnant, and as their age moves on, there is a series of programs, preventive programs that are very important for their health and that are really underlined. And then, well, here, sometimes women decide to have or not to have children. And in this area, the system is slightly better. I'm going to share some data because basically the healthcare system in Mexico, as it is the case in many other countries, is directed to provide care and to cure. But there is no prevention programs, which are so important in building life habits. And this is absolutely key. And then we have, of course, the needs that a grown-up women needs for that are also very important. Let me start sharing with you a bit about what has to do with the healthcare system. We have to acknowledge that the healthcare center, yeah, healthcare services have been present for years and years and years with great deficiencies. For years and years, the uh, it is half private, half public. People that have healthcare in private services is not regulated. It is quite an expense, more so for the poorest one. So there is a structural problem in the healthcare system because it's centering its attention in curing people, and why we have not strengthened this enough as in order to consider the levels of demand, even with the Seguro Popular, because the Seguro Popular brought more funds to the system. It did not manage through the public system to expand and improve its quality to provide healthcare to all the affiliates. There was an enormous number of the population affiliated, but this population was unable to receive the services as it would be expected because the supply was not open. We have a serious problem that, of course, given everything that my colleagues have shared with you, what became much more serious, not only during this administration, but also given the pandemic. So there is a cascade of healthcare attention. Now, these are official figures. What we ask them is if people have had any healthcare need in the last 3 months, if they looked for healthcare, if they received the healthcare, and we are also interested in finding out where they were looked after, where the healthcare was given to them. This is 2020. 18.6% of the population has some type of a healthcare need, 82% was looking for attention, 81% received attention, but only 34% received attention in public services. This is what has been happening. And in this year, given the reconversion of hospitals. Now, how do we see this? If we compare this in regards to men and women, there's a point that I want to share with you. You know, women use more healthcare services. Uh, that is not the idea, but we did. In regards to men, we had 16% of them had a health need. 81% of them looked for healthcare attention. 79% received attention, and 32 received attention in public services. In contrast, women report that they have more healthcare needs, as it is to be expected, 21%. A higher proportion looked for attention, 84%. A higher proportion received attention, 82%. And 36%, which is also higher than males, received attention in public services, because many of the women have give birth in public services. It's very expensive to do this in the private sector. Or there are also private sector that cannot do this, such as those doctor's offices that are attached to a drugstore. Now, one of the main concerns in the health area is the fact that there is a problem in the level of supply. So regardless of the person that has the right to healthcare, people tend to go to the private sector. For example, half of them of the affiliate go to private sector. This happens for men and women, and even more in those that are affiliated to ISTE, which is the Social Security of governmental programs. Now, it calls our attention that the population that do not have healthcare services, that includes those with Seguro Popular, more than half of them would go to the private sector because the Seguro Popular people were affiliated, but the supply was not enough. And you can see this in the different columns, the difference of the population that do not have the right can go to the clinics of the health ministry. Clinics. What you can see here is that population with no social security is the most vulnerable. You can see that the great majority has healthcare in the private sector. And this is quite unique when we compare it and see that men and women have the services, but women tend to go to the public sector. Now, what is the problem? Well, that the private sector is not regulated, nor the quality of services, unless it's a highly consolidated hospital, which is very expensive. Very few people have access, but it is not what has to do with the quality. There's quite an expense that is impacting and affecting the poorest of the population. Now, in terms of some health indicators, there are many areas regarding women. I'm not going to share all of them with you, but this is the prevalence of high blood pressure in adults. Here, by sex and gender, we can see that from 50 on, women are more hypertense from 50 to 80 levels years of age in regards to men. In the survey, we have outcomes given the findings in the surveys. The participants did not know this, and with lab tests, we can know and have a previous diagnosis. It all of the age ranges, what you can see when I was talking about hypertension, well, it's higher in women,
el saberlo, lo
but
saben
women,
más, saben, o sea, por diagnóstico previo, porque las
the
mujeres
fact of knowing this, they know of this much more because we women go more to the healthcare services, and we do this given our healthcare needs, but also because we are caretakers and we're also looking after our children. So we have more contact with the healthcare services, even though there are limitations in the health services. This is a sample of this. Women know more of their hypertension than men because they go far more often to the healthcare services. The prevalence of diabetes is also present. There's no inequality in regards to the total prevalence, which is about 15% in men, and the same number goes for women. But what calls our attention is that there is a higher proportion of diabetes by a previous diagnosis. A higher proportion of women know that they have diabetes in comparison with men. And this is because we go to healthcare services more often. In terms of preventive programs, really, I have two examples to share with you, and there is below the optimal level. But it's quite important to see the case of women, where you can see how the proportion of women that are reporting that they have had a Papa Nicolau test or a clinical exploration of their breast is very low. In total, it is 28.9%. The same goes for the clinical breast exploration is really very low. And if we see this in terms of a mastography and other preventive studies for the breast cancer, it's the same story. It's below the right level. And why is this? Well, that is because we do not have good preventive programs that will reach women that would not go to these services, given many barriers, or they don't have it close to their where they live. And let me go back to another argument in regards to detecting diabetes or hypertension. What you can see is the detection is higher in women than in men. You know, that is because we go more often to the healthcare services than men. So diabetes identification, 13% in men and 17% in women. In the case of hypertension, we have the same situation, 14.2% in women, where the detection is below the optimum level, and we have also another level in men. Now, something that is very important is crucial in the lives of women, among many other things that have been mentioned, is the beginning of their sexual life and adolescent pregnancy. The beginning of the sexual uh, life between 12 to 19, 24% of men start their sexual life at this age, and 18% of women. But what is really impressive, and this is where it is quite obvious to see the lost opportunities for this to change, is that they are reporting of that 18% of women that started their sexual life, 46% were pregnant and 22% at the moment of the survey. What you can see within this graph, these are data from 2018 in comparison to 2012. And you can see for the first relationship with no unprotected sex, there's a high level of women that started their sexual life and they were unprotected, 34% versus 23%. So these are key elements, and they tell us that we're still missing friendly programs and information which is crucial for adolescents. In the case of prenatal healthcare, what we can say for children between 12 and 19, well, you may see, as I was telling you, that the system is centered more in the curing area or the healing area than in the preventive area, where we can see that 97% of women had health care given their pregnancy, but they started during the first quarter of their pregnancy. Only 74% started health care. There's a problem here because many of the problems associated to pregnancy can be identified from the very beginning of pregnancy and as it moves on in time. So in the case of adult women, in this graph that I'm sharing with you, with the distribution of women in terms of the number of prenatal supervisions and healthcare visits, Here, this is a suboptimal level. You can see how 88% of pregnant women comply with this requirement of 5 and more. So the woman and the baby will be in a good condition. So we have enormous opportunities here. Let me go back to breastfeeding, which is so very important. This is quite an example among many. This is breastfeeding. You know, maternal milk has multiple benefits for children in terms of breathing diseases, otitis, medium otitis, gastroenteritis in areas of mobility, but also in regards to mothers, because the breastfeeding are protecting you against diabetes, also diabetes, breast cancer, ovary cancer, and hypertension. And unfortunately, breastfeeding in Mexico is suboptimal. You know, the prevalence in other countries in Latin America is quite low, but in this, along this line, even in comparison with Peru, that has, you know, 95% levels, there is no reason for women not to be able to breastfeed our children. There are no reasons for this. So we have studied this topic. It is an example of what we can do in other areas of women's health care. How much does it cost the country not to have optimal breastfeeding indexes? So for boys, we can see the mortality levels, but how much does it cost to the country regarding all of this? And this is between 745 to $2 billion, $2.5 billion. And for mothers, in terms of the cost for not having prevented all of the associated diseases and illnesses, is $1.116 billion. So these amounts are sharing the decision makers how much we're losing in terms of public health, but also in economic rights, in not having all of these actions in favor of mother's health. To conclude, what I would wanted to highlight in this presentation was the fact of sharing this idea that the healthcare system in Mexico has been for years and years dealing with cures and healings. It has been for years not being enough for the population that does not have the right, they're not right holders at the Social Security. It is important to expand the healthcare services. It is very important to improve the quality of the healthcare services and all of the other topics that I have shared with you. But also, this also happened with the popular Seguro Popular, and now with Insabi, it's far more delicate. Now, clearly, there is a gap in in the prevention area in all ages of women. And it's key to start from the early childhood, from the first infancy. Now, health in the case of women.
De la población en general, pero en particular de la mujer, por todo lo que vive y por la heterogeneidad de las mujeres, debe tener un enfoque integral. Y entonces, no solo es salud, es educación, es todo, es sectorial. La sexualidad es clave en esto. Y entonces, básicamente, lo que tenemos es que caminar hacia programas integrales y sectoriales. No puede estar solo, no podemos estar pensando solo en salud, sino todo lo que implican las necesidades de la mujer a lo largo de su vida. Con esto termino. Muchísimas gracias.
Doctora, muchísimas gracias por una gran presentación. Me parece que el énfasis que le pone a la educación en infancia, adolescencia, en una edad reproductiva es sumamente importante. Nada más para resumir una porción muy pequeña de toda la información que nos proporcionó. Por cuestiones de tiempo, vamos a iniciar con la sesión de preguntas y respuestas. Nos han llegado ya varias preguntas dirigidas a cada una de ustedes, entonces les voy a pedir que por favor sean breves en sus respuestas para que podamos hacer todas las preguntas que nos han llegado. La primera es para la maestra Irene Tello. Esta persona, lo voy a traducir porque está en inglés,
pero dice que cuánto de los datos que ofreció viene de zonas rurales. Es decir, esta persona dice que trabaja en 6 estados rurales y que ha visto que este programa de desabasto de medicamentos a veces es sacado de proporción. Es decir, para un poco enfatizar lo que quiere decir, ¿cuánto de los datos que usted ofreció se enfocan en zonas rurales en cuanto al desabasto de medicamentos?
Mil gracias. Por lo que yo sé, no podríamos saber esta información y aquí creo que es donde es importante contextualizar. Este es un trabajo que debería estar haciendo el gobierno federal. Ellos cambiaron el sistema de compras, ellos tendrían que estar midiendo el número de recetas no surtidas y cuáles son los estados más afectados. Desgraciadamente no lo están haciendo y estamos siendo sociedad civil los que con las herramientas que tenemos, como puede ser el colectivo Cero Desabasto, tiene una plataforma para poder meter reportes. Ahí pueden ver los estados que más reportes tienen. Sin embargo, ahí con esa información siempre pasa con que no sabemos qué tanto es que las zonas que tienen más conectividad de internet, como pueden ser Ciudad de México, Nuevo León, o que tienen más conocimiento de esta plataforma, están reportando más, pero tanto por lo que dijo la diputada como por otros datos que nosotros hemos visto de ya las carencias que tenían el sector salud en zona rural, esto me queda claro que les está afectando también considerablemente a ellos. Solamente para poner un ejemplo y que también lo mencionó la diputada, tenemos ahorita 2 problemas. No hay un sistema de compra consolidado todavía, se están dividiendo el tema de las compras entre INSABI y UNOV sin lograr realmente comprar lo que se requiere para todo el país. Y el segundo gran tema que no se ha resuelto es el tema de distribución. El tema de distribución no solamente es de repartir almacenes, sino como bien mencionaba la diputada, a cada una de las zonas donde se requiere el medicamento. Si ya de por sí esto antes era un reto, me queda claro que ahorita como no se sigue sin arreglar el tema de la última milla, que definitivamente está afectando también a zonas rurales.
Muchas gracias, maestra Tello. Esta pregunta es para usted, diputada. ¿Por dónde se debe empezar para mejorar el tipo y la calidad de acceso a los servicios de salud de la mujer? ¿Cuáles serían los cambios que pediría en orden de prioridad en la cartita Santa Claus?
La educación, o sea, yo soy un claro ejemplo, aprendí a hablar mi lengua, el español ya de grande porque mi origen ya había definido mi destino, que era repetir la historia de mamá, de la abuela y tener un hijo, tener un chingo de hijos. Y entonces desafié esa circunstancia y arrebaté a la vida lo que creo que es la herramienta más poderosa, que es la educación y entender cuáles son mis derechos, que yo decido sobre este cuerpo, que es mi responsabilidad, y cuántos hijos tener, que yo tengo derecho de ir a revisarme y que eso no va a perder mi identidad y mi cultura, que yo vaya a ver un doctor para mi papá Nicolau, para mi mastografía, mientras que no seamos capaces de llevar ese mensaje a las niñas de las comunidades indígenas, a las mujeres de las comunidades indígenas, pues va a seguir siendo un reto de verdad, y traducir la política pública en las lenguas indígenas. Lo digo aquí, lo he dicho siempre, lo he gritado desde la sociedad civil, por eso estoy en la política también, porque más allá de la plataforma política, es mi convicción, porque de ahí vengo, porque nos dicen las cosas en Castilla y nosotros los que hablamos una lengua diferente al español no razonamos en español, razonamos en nuestra lengua materna. Entonces, por eso es un reto, la educación y traducir la política pública en las lenguas.
Gracias, diputada. Doctora Colchero, ¿qué papel juegan los hombres en prevenir y abordar los desafíos en los sistemas de salud que se enfrentan las mujeres?
Interesante pregunta. Yo creo que no deberíamos de ver las necesidades de salud necesariamente aisladas de las necesidades de los hombres, ¿no? Un ejemplo muy interesante es la vacuna de VPH. La vacuna de VPH es una vacuna solidaria, ¿no? Y aunque los hombres también tienen algunos problemas de salud derivados, básicamente se le pone al niño para proteger a las niñas, ¿no? Entonces, digo, no sé si contesto la pregunta si era en ese sentido, pero por ejemplo, esto que yo mencionaba de introducir pronto en la infancia la educación sexual tiene que ver con introducirla para niños y para niñas juntos, porque justamente si en ese periodo el énfasis es tienes que cuidarte, tienes que estar alerta y saber qué es lo que no está bien para ti, qué es lo que está bien para ti. Eso es para los dos, ¿no? Y entonces también el niño puede hacerse consciente de lo que no debe hacerle a la niña y etcétera, ¿no? Entonces, yo creo que a lo largo de la vida la mujer no está sola, ¿no? La mujer convive también con hombres y entonces cuanto más se involucre, y podemos ayudar a que caminen juntos, lo cual no es fácil, ¿no? Pero no sé si desde esa perspectiva era, era la pregunta, ¿no? Porque obviamente también
Have this
tiene que ver
question.
con la
Obviously,
decisión de tener
this has to
hijos,
do
también
with the
puede,
decision of
puede
having
ser una
children,
decisión
if it has to do with the
fuerte
decision
cuando se
of
inicia
looking after yourselves
la vida
when
sexual.
the sexual life
Es
starts.
muy importante
It is
que las
very
mujeres
important
tengan
that
las herramientas para
women will
decidir,
have
pero
the
no,
tools to
no
decide on
siempre
this.
no nos dejamos convencer. Entonces,
And
yo
then
creo
we
que
were
algo que
not
le puede hacer en este
convinced
caso
about this. I believe that women must be
eh,
empowered,
los
but
hombres
also
acompañar, pues
men
saber cuáles son las
uh,
necesidades de
must
salud de las
know
mujeres.
which
Y en
are
rurales,
the
rurales como decía,
needs of
en
women
áreas
and
donde
other
no es
areas
necesario que
where
haya por
uh,
administrativos,
they
para
don't,
sus
men do not want
bueno,
their
es
girls to
mucho
go
más
to the healthcare
que
centers
se
because
pudiera
of contraceptives
mezclar,
and preventive
Eso
pregnancy,
sería
for
la
example.
pregunta.
That is
Yo
what I
le doy
wanted
la
to share with
palabra
you.
a las
I
tres
have a
panelias para
question
contestar
to the
con
three of you. Let's
responsabilidad.
see who wants to
¿Qué
answer.
se dedica
Welcome.
a
You are
esta imagen de
dedicated
mujer
to
que
the
vivió
topic
la
of
vida en carne propia,
women's
¿no? Y
health, and
también
you have lived through
recientemente en
this,
México yo lo he
but
vivido
also being women,
hace
I
algunos
can
años.
understand this. Sometimes it's difficult.
¿Ven algún
Now,
cambio
can you
en
see any
comparación a cómo
change?
venía el sistema de salud en México en otros gobiernos al actual? Es decir, heredó un sistema quebrado
So that
el
means that
gobierno actual.
the government
Eso se
inherited
refiere
a
a la
broken
política
system, or
pública
these are public
que el
policies
gobierno de
of
México
the Mexican
actualmente
government
están
uh,
tal vez haciendo que sea aún más difícil que las mujeres
that
tengan
is
acceso
making
a
even more
salud.
difficult that women would have access to
Adelante,
health.
bienvenida.
If anyone would like to answer,
Yo sí
please.
puedo decir que heredaron un sistema
Well,
con
let me
muchos
say to
retos
you that they inherited a
y
system with
con sus
many
decisiones
challenges,
lo quebraron.
and
Y
with their decision,
desafortunadamente tenemos
they
un sistema de
actually
salud quebrada
have bankrupted the
como les
system.
decía, el
We have a
programa de
broken
vacunas que
system.
se hizo
You
sin
know,
un
the
plan de
procurement
cómo se
system
iban a comprar
without an
medicamentos,
alternative plan of how they were going to buy
ausencia de asegurar que
this
los
medicine
que nos
to
dedicaban a
vanish
servir
the
en salud
Seguro Popular.
hicieron esa
We
corrupción.
have
El
studied
Seguro
corruption
Popular,
in the
una de las
health sector with Seguro
recomendaciones
Popular. One of the
si no
recommendations we
tenían
made, if
corrupción
they wouldn't have this level of
las
corruption,
autoridades
just
iban a
imagine
ir a
the
las
quality of
calles a
services that they could
organizar
provide us with.
protestas y que la
But
gente
it was
estuviera
obvious that
feliz
a service was
con el
given,
Seguro Popular.
and people that were
Hoy la
receiving
verdad
Seguro Popular were very happy with the services
después
they
de
were
todo
receiving.
el
To
coqueteo que se
vanish
hizo con
this
todas de las
was
pruebas de
another of the
vacunación,
major mistakes of the
estamos
current
viendo con el INSABI
administration.
que no
We're
está
seeing
pudiendo
with
dar la
Insabi
tasa que
that they're
tenía
not
el Seguro
capable
Popular
of
y ahorita
providing
nuevamente están
attention with the
proponiendo
Seguro
un cambio.
Popular,
Yo sí
and
puedo
now they're
decir que
proposing
no
a new
estará
change.
bien
And
con
now
el actual
it is not
consejero de
quarreling with the current
nutrición. Quien
administration.
haya sido del partido que haya
Whomever
tomado
it
esas
is,
decisiones se tendría que llamar a cuentas. Eso es lo que tendremos que ver y
we
sí,
have to
definitivamente creo que
be
estamos en un
liable
peor
of
lugar
this.
que en el que estábamos en
I
administraciones
mean, we're in a
pasadas.
worse situation than we were in previous administration. Just an announcement for our attendance. There was a technical failure with our interpretation, but I think it's working okay. It is the globe icon in the lower part of your screen. Madam Representative, just to respond to your question, let me add an additional component. If you would have to take the decision of a single change in the healthcare system, what do you think will be good? What do you think will be important or what needs to be done to improve the system that we currently have in Mexico? Well, I totally agree with Cristi and Irene. And yes, I mean, we lost what we have achieved. I am beyond this is beyond a party policy. It is a matter that has to do with how we have struggled to consolidate the national inoculation system in Mexico, that now in an automatic way, they were inoculation days of diseases that I have to endure, that my brothers and sisters died because of missiles
para que nos vacunáramos y cómo mis
and smallpox. I mean, this is something that no one has to tell me. I mean, we had to walk for 12 hours to be inoculated, and how I could see that a person with a white robe would come to our home and back and inoculate children, and overnight this was just vanished and deleted. Let me say this: healthcare is not a banner of any political party. It is a flag that all Mexicans have to embrace to prevent any children dying from measles or for smallpox or whatever health situation. In the national health care system, there are many children in indigenous communities that do not have their basic inoculation element. It is not something that has to do with political colors. It has to do with the health of boys and girls. What is dangerous is that those diseases can come back again. I mean, that is much more dangerous than COVID. That is why it is urgent to do this. So what will I do? Well, I will put capable people so we will not waste time in bidding processes because we have the resources adopted and allocated and actually earmarked within our budget. So this money has to be invested in areas that are a priority, not such as healthcare, not in other areas that are not important. So, well, this healthcare system, whomever is there, they should really know of it, and the bidding processes or tendering processes will not be acting as a bottleneck, as we say, in order not to make more agile the fact that their medication will not be basically operating. Well, Dr. Colchero, I have a last question for you. What can we do to improve the awareness of the need of preventive care for women? How can we do this? Well, I think it has to do with a joint effort because even I believe that it is very important to consider education, disseminating messages, yet they are not enough. We have to consider the existing barriers. And as a matter of fact, when we say that this is a matter of awareness, it leaves out everyone's conscious. Unless they provide you with this, you do not know of them. So yes, you have to know that you have rights, but it's important for you to attend to preventive programs, but they have to be made available. They have to be friendly and they have to be fully dedicated to the population in its different moments. So retaking the healthcare system, it has been below the optimal level for many years. It is this issue regarding consolidated purchases was really important. You know, this consolidated purchasing can be an efficient mechanism to buy medical drugs because you can save money and avoid corruption, but you do not need to consolidate everything because there are certain medical drugs that represent most of the budget. You start with a pilot test, you fine tune the processes, and it is very important because finally you will avoid corruption. I think that the healthcare system has to have a reform in place that calls for many, many things. One of them is a lot of resources. The resources for health are insufficient. If we want a healthcare system of universal coverage, more so for the poorest one, we need money. Without it, we will not achieve that. We have to make it far more efficient and make it of higher quality. It is quite a challenge, given the fact that it is worn out and it is also fragmented. We have EAMS, ISTE, the Ministry of Health, and they're so highly fragmented. So it's up to your labor condition. You have access to health, and the type of access has to do with your labor condition when it is not. It is the right to health is a human right. That is an incredible challenge. I mean, you have to have access of coverage that must be efficient and of quality. It is quite a challenge, and I think we have to do this at one point. Well, unfortunately, we have run out of time. It has been a true honor for me to be the moderator of this deluxe panel. I have learned a lot from the three of you. On behalf of the Wilson Center at the Mexico Institute, we thank Irene Tello, Eufrosina Cruz, and Aranza Colchero. We thank you for your time, and we thank all of you who have participated of this session. There will be a recording in our website. If you want to check it, you can do so in the following weeks. I certainly thank all of you. We thank you for being with us, and I hope I will get to see you very soon. Thank you very much for being invited. It has been a true honor. Thank you very much, and best greetings from Oaxaca.